Good afternoon, everyone. Thank you so much for joining us today. We are right at the top of the hour, 2 o'clock, so we are going to go ahead and get started in our presentation on reviewing HEDIS quality and telehealth services. So we're glad you're here and look forward to sharing this information with you. Before we get started, of course, we want to go over a few housekeeping items. We'd really like to leave the mute management up to you all. That way you can easily come off mute to ask questions or make comments or participate in the presentation. So we're just going to ask up front if you all could mute your line when you're not speaking so we don't get that background noise. And then, of course, coming off mute when you do want to ask a question or make a comment. We are going to be monitoring the chat box, so feel free to use that for questions or comments if that's more comfortable or easy for you. And then we plan to incorporate breaks in the speaking, so you will have the opportunity to chime in. We are definitely not super well versed in the art of virtual collaboration and presentation trainings. Normally, I think we're out actually connecting with you all, so we're going to do our best here and just ask that you kind of help us along. One specific session I do want to call out. We're glad you're here today and wanted to mention next Friday with the forum. So we have 3 sessions like today's presentation, this being one of them. But next Friday is the open forum to discuss quality in telehealth, but also just telehealth in general. So we've heard a lot of different experiences in the transition to telehealth. And we've heard some groups that have had really great success. And then we've also heard from other groups that are having ongoing struggles or who have encountered a number of different barriers, some which they've addressed and others that I think folks are continuing to struggle with. So we're really hoping that that forum creates a platform for everyone to come together and share and learn from each other as primary care peers. So I did include some reflective questions there that might help you or your teams prepare for that conversation, but just wanted to call out if you are available to join us. Sorry it's during lunch. You can eat with us next Friday, the 26th. Aha. So with that, we'll move into the presentation that we're actually here for. I mentioned we don't have much experience with the virtual stuff, but I've sat in my fair share of vendor presentations and they always seem to do this, where they put their faces up so you know who you're talking to. So I'm taking a page out of their playbook. And since we'll be the ones really presenting a lot of this information today, we thought it'd be nice if you knew who we were. So we'll do just some brief introductions. Rebecca, if you want to start us off.
So I'm up here on the left. My name is Rebecca Allenheima. I'm a program manager on our quality team at PHP. I primarily work with our commercial and Medicare incentive programs with a sprinkling of all other things quality, including telehealth now.
Ruben.
Hi. Hi, my name is Ruben Halperin. I'm one of the medical directors for Providence Health Plan, specifically the medical director for quality, and I oversee a lot of the quality activities and serve on the committees that are involved with quality measures like HEDIS and Medicare STARS.
I'm Sarah Gardner-Smith. I am one of the strategic accounts managers here at Providence Health Plan. And I work primarily with you all in primary care to support a number of different activities like risk adjustment and alternative payment model success, and of course, quality being a big component of that. So I presume I know a number of you from our work together, and others may work with my counterpart, strategic accounts manager, or other folks here at the health plan. So with that, I think we'll just take a moment to hear from Ruben and kind of set the stage for and reflect on the importance of this work.
Thank you, Sarah. So we're here today because of our commitment to quality in healthcare. PHP has a robust infrastructure dedicated to measuring and reporting quality and to troubleshooting and innovating solutions. The COVID epidemic or pandemic has disrupted healthcare just as it's disrupted many of society's institutions that we take for granted. In a very short time, we've seen massive changes in hospital and clinic protocols, an overnight suspension of elective services, and a dramatic decrease in in-person interactions. It's tempting during a crisis as widespread as COVID to forego collection of quality data and to hunker down into an emergency mode of just delivering the bare essentials of medicine. There is so much fear about the present and the future. Will we see our patients again? Will our staff stay healthy? Will we survive financially? At this difficult time, however, it's critical that we reaffirm our commitment to quality. We have all worked hard over the years to bring quality measures up to NCQA defined goals. Rather than letting that slide for now with the hopes that this crisis will soon be over and things will return to normal, it's imperative to find a way, given the current constraints, to keep moving forward. A crisis provides opportunity. Since March, we have seen a rapid uptake of telehealth in medicine, fulfilling predictions that were made years ago but continue to dangle tantalizingly in the future. Telehealth offers the opportunity to engage with all patients during the pandemic, but now and going forward, it also offers the opportunity to engage with populations who historically present challenges, such as patients with physical disabilities, mental health issues, or limited transportation options. We also see it as an opportunity to expand the universe of patients who receive routine health wellness care by making it more convenient for patients to have meaningful interactions with their healthcare providers. We welcome all of you and applaud your participation and commitment to strengthening healthcare quality going forward. Thank you.
Thanks, Ruben, and thanks everyone for joining us today. All right, we do have a few disclaimers. The first one actually not on the slide is that I am recording today. It just helps for us in facilitating the conversation, but also in capturing the question and answers that come up so we can use those to inform future conversations and education. So wanted to make sure everyone was aware of that. We are here to share the alignment between HEDIS and PHP payment policies, and just want to be clear that we're not giving an exhaustive training on coding or on HEDIS measurement. So folks who, some of you are on the phone, who work in coding or HEDIS measurement, clinical quality, know that we could never even touch that universe in, an hour conversation today. So, this is really a subset of that intersection that we found most valuable. We're also not providing guidance on billing, coding, or reimbursement. And when it comes to that, we really direct you back to the relevant payment policies. Those will give you, as you know and use now, the best information on billing and coding. As I think we've all experienced to the nth degree recently, how often this information is changing. So this information is accurate based on what we know today. Rebecca and Ruben and I went to great lengths to make sure it was accurate as of 1:55 p.m. But it does continue to evolve as new policies and guidance are released. So we'll continue to communicate those updates, but just want to ensure that you know that this PowerPoint will only be as accurate as long as those policies are not changing or haven't changed. And finally, just guidance that we provide here. We can't guarantee HEDIS credit. We do run HEDIS entirely in-house, so we have a lot of robust expertise that we've leveraged to create this educational information and our strategic recommendations, but these activities are subject to the whole HEDIS review process at the time of measurement. So we're doing our best to educate and make sure you have all the information so that we're all successful, but we can't actually guarantee anything at this point. So, all right, disclaimers aside, we can move on to the good stuff. So once again, our goal today is to better understand how telehealth and quality coexist. So we've taken the PHP telehealth payment policies and we've effectively crosswalked it with the NCQA HEDIS guidance on which activities they've said are accepted and measured when performed via telehealth. And to be clear, telehealth as defined throughout this conversation and this presentation refers to two-way audio video visits. So PHP pays for audio only visits. We have for years, and that didn't change with COVID. And we ask providers to be strategic about when to use audio only versus telehealth. You know, there's specific policies for audio only visits, and unfortunately, those can't be used for other parts of population health payment, like risk adjustment, for instance, an important one. But for the purposes of the discussion today, we're going to talk about how to be successful in achieving quality via telehealth. So we're talking again about the audio and video visits. The key messages we want to start with are just a broad view of telehealth and quality. We'll talk about the most common CPT codes that are captured as part of HEDIS billing. We have a number of years to look at what we've seen in billing for that. And then the importance of diagnosis codes and CPT category 2 codes for that measurement. We will spend some time reviewing and discussing a broad 2020 strategy for clinical quality. I know that the year hasn't really gone how anyone expected, so trying to give you something kind of served up, a grab and go, if you will, to help support your quality efforts. So we go actually deep dive into individual measures and associated quality strategies. I will note another thing, so I guess I'm not done with the disclaimers quite yet. The universe of codes is enormous. Again, those of you in coding know this, and the code set associated with HEDIS is really complicated and also vast. So in order to create this content that we thought would be most useful and relevant for right now, we prioritized the measures into what we're referring to as tier 1. So it's distilled information based on like volume of codes and HEDIS measure that are what we call high value. So they appear in multiple quality programs. That's what we're focused on today. So it's just not an exhaustive report out. We can have more targeted conversations if there's specific measures that you don't see here and want to talk about, but it's not an exhaustive list. We'd be here all week if we did that. First things first, at this time, NCQA has not approved telehealth service for well child checks as part of HEDIS quality measurement. So that's the well child checks for the first 15 months, the 3 to 6 years, and then also the adolescent well care. You can see from my starred notes at the bottom here, we have been advocating that NCQA address that and make special provisions for COVID to allow for billing of those. But at this time, that's not the case for HEDIS. So OHA, those of you who participate in Medicaid, whether with us or with another CCO, OHA has decided to lift the telehealth exclusion from the W34 measure, which is one of the CCO metrics. And OHA indicates that they'll provide credit for that for visits completed in telehealth in 2020. So that's separate from HEDIS. But since many of you do provide Medicaid services, we thought it was worthy of mention today. And then one other thing that we actually just learned last week was NCQA gave us sort of a moment of insight in some more guidance coming from them on telehealth eligibility for a number of measures. And it included these well care measures. So they didn't come out and say that they were going to allow telehealth on them. But we're optimistic that they will and would expect, if that's the case, that it would go back to January 1st. So it would be relevant for all year. So again, no final decisions. They used carefully chosen words that made us hopeful that guidance is coming when they release additional specifications on July 1st. So we'll communicate those, of course, as we find them, but wanted to share that at this point, official guidance indicates telehealth is not included. To that end, PHP telehealth policies cover these services. The well care visit codes, including the 10 that we saw most frequently billed in 2019. So our stance is to encourage that you continue to engage with those kids and regardless of their inclusion in HEDIS. Quick pause. Any thoughts or questions or reactions to this information or the information shared thus far? Okay. I'm a talker, so I have to pause to let you talk. On this slide, I think before we get into the weeds, kind of just stay at the higher 30,000-foot view. It's really not necessarily about the individual codes that we listed here, but the overarching message that we call out in the header. So the 5 CPT codes account for more than 70% of primary care quality reporting data capture. So we looked at all the HEDIS reporting in measurement year 2019 and reviewed those codes most commonly billed across all of our HEDIS measures. So tried to get a really broad picture of what codes are coming in as part of our claims reporting for HEDIS. And we found these 5 codes were a component of HEDIS reporting 70% of the time. And all of these are covered by PHP telehealth payment policy. So what that means is that while telehealth feels really new and intimidating, and in so many ways it is, in the clinical quality HEDIS reporting space, it's not fundamentally changed. So in our pre-COVID world, the E&M code served as the driver of the indicated quality activity. You know, they're the venue through which we achieve the clinical outcome, the quality outcome, using that office visit within a certain time period or to discuss medications and ensure adherence, you know, complete a referral, order labs, et cetera. So that really continues to be the case in this telehealth world. And those most popular codes that we were already seeing being billed are covered under PHP telehealth payment policies, and they are captured as part of our HEDIS reporting. So want to represent that those things in a year that feels like so much change, that we're seeing that this area isn't fundamentally different.
Okay, this is Rebecca speaking now. We're going to change up the presenters a little bit. So as Sarah mentioned, the E&M code is often the driver of the quality activity, but oftentimes the measures look for more information in order to confirm compliance. So they go beyond just the office visit, and through the analysis we completed, we found that this often falls into 3 primary categories. So we have those listed here. That would be an encounter with a provider within a specified time period, medication use or adherence, or services rendered, such as a lab test or a screening of some sort. So in some cases, we found that these numerator hits are captured based on the submission of a diagnosis code or a CPT Category 2 code associated with one of these 3 categories. So in this COVID environment that we're in right now, and especially, does someone have a question? Okay, I'll continue.
I think just a mute reminder.
With accommodations for chart review unknown, diagnosis codes and CPT2 code capture will be of increased importance to make sure that we can capture information administratively as much as possible. Next slide. So I'm going to dig into this a little deeper here. This is an overview of the highest volume diagnosis codes that were used to capture administrative hits in 2019 when we completed our analysis that Sarah explained a few slides ago. So I'm not going to review this in too much depth, but I'll just call special attention to prenatal and postpartum care, or the TPC measure at the top. So for both elements of this measure, what we often saw was an E&M code paired with a diagnosis code for either prenatal or postpartum care. So the diagnosis codes up here are not an exhaustive list because there's simply too many diagnosis codes for this measure to list. These are just the most commonly used ones that we saw associated with HEDIS quality reporting. And this is not advice on coding or billing of any sort. This is just an example of what we observed and a reminder to continue including this information when it's relevant so that we can pick up this information administratively, whether it's billed in person or in a telehealth environment. Next slide. So this is a similar chart, but for CPT Category 2 codes, which are used today or have been used in a pre-COVID environment, but just not quite or nearly as often as diagnosis codes, or may not be as familiar to all of you. So a good example here that I think is more commonly known as medication reconciliation post-discharge, which is the 1111F CPT2 code. So it can be used associated with that measure to capture an administrative hit. So when you add those CPT Category 2 codes when they're relevant, it can help to simplify the review process when it comes time to measure HEDIS. Are there any questions on those last couple of slides that I just reviewed? Okay, next slide. So just to sum up this section before moving into a review of specific measures, the key messages that we really want to portray is that clinical quality is still possible in a telehealth environment, and it doesn't require significant process change in order to fulfill quality in a telehealth environment. And while care delivery may look different and feel different through telehealth, many of your quality workflows can still stay in place virtually, and this includes the coding that you've used in prior years. And telehealth visits will serve as the chassis for quality activities, but capturing diagnosis and CPT Category 2 codes will be a key component to drive your quality reporting. This was already true in a pre-COVID environment, but it will continue to be even more true today. I see a question here in the chat about telephone visits as well as E&M visits. So the presentation that we are giving is specific to two-way audio-video visits. There may be certain circumstances in which HEDIS allows telephone visits. We call that out on the specific measures, but for the most part, we're only addressing audio-video. If you have questions about specific measures and fulfilling them via telephone, you're welcome to reach out to us directly and we can see if we have information on those. Are there any questions before we begin reviewing specific quality measures? Okay, so now we're going to dive into a discussion of quality strategy in a telehealth environment. So here we've laid out a quality strategy framework that we've put together specific to a telehealth environment. I want to say it's 17 measures. We started out with 15, and then I believe we added 2 more. So it should be 17, but I haven't exactly counted since we added a few measures to this presentation. We did do a deeper dive on a larger measure set than just this. So if you're interested in learning more about a measure that isn't represented here, or again, something like telephone visits, feel free to reach out to us directly after the presentation. And if we have more information, we're happy to have a longer conversation with you about that. But these are the measures that we'll be reviewing today. The first section is titled Healthy Women and Children. This includes the prenatal and postpartum care measure, well child visits, adolescent well care visits, and weight assessment and counseling for nutrition and activity for children and adolescents. So the first measure is prenatal and postpartum care, or PPC. It's a 2-part measure. The first component is a prenatal visit completed within the first trimester. The second component is a postpartum visit completed on or between 7 and 84 days after delivery. Both of these components can be completed via telehealth if it's appropriate for the patient. Of course, you'll want to consider the patient's specific circumstances to determine if there's a need for an in-person visit. And as we touched on earlier, complete capture of diagnosis codes and also CPT Category 2 codes is very important for administrative capture of this measure. Next slide. These are the 2 well child visit measures that Sarah touched on earlier, W15 and W34. So this looks at completion of recommended well child visits for specific age groups within an appropriate time period. So we touched on the fact that these measures are currently not accepted for quality reporting in a telehealth environment. We are hoping that that will change for all of 2020 when NCQA releases new specifications on July 1st. We don't know that for sure, but we are cautiously optimistic. The reason that these visits aren't eligible for quality reporting right now, when completed via telehealth, is because they require the completion of a physical exam, which cannot be done via telehealth, and the measure cannot be fulfilled without the physical exam. PHP does include many outpatient codes in our telehealth payment policies, so we recommend staying engaged with these patients via telehealth and scheduling in-office appointments when necessary. Next, oh, there we go. So this is the adolescent well-care visit measure. Again, Sarah did touch on this one. It looks for the completion of a well-care visit for patients aged 12 to 21 years within the appropriate time period. Similar to the well-child visit measures, this also requires a physical exam, and for that reason, it's not currently eligible for quality reporting via telehealth. We are hopeful that NCQA will come out with provisions to allow this, at least for the COVID period, with new specifications. But again, we need to wait for final comment from NCQA on July 1st to confirm that. We do have several outpatient codes available for telehealth for this measure to maintain patient engagement, so please stay engaged with these patients. So this measure is called WCC. I think myself included, it's often confused for well-child checks, but what it actually stands for is Weight Assessment and Counseling for Nutrition and Activity for Children and Adolescents. Bit of a mouthful. So this is a three-part measure. It includes nutrition counseling, physical activity counseling, and capture of a BMI percentile. Nutritional counseling and physical activity counseling completed via telehealth can easily be identified via diagnosis code. But one word of caution related to BMI percentile is that HEDIS has not yet weighed in on whether patient-reported vitals via telehealth are acceptable for quality reporting. We're hoping that NCQA will address this component in the new specifications that will be released on July 1st. And we recommend that you continue to capture this information for its clinical value, ideally with a parent present. And then in the event that this is allowed for quality reporting, we would be able to capture it administratively when it's billed with a diagnosis code, but we don't know today if that information will be accepted for quality reporting. Are there any questions on the women and children section before we move to the next section? Okay, this next section is people with diabetes, and it includes the comprehensive diabetes care and statins in persons with diabetes measures. The first measure in this section is comprehensive diabetes care, or CDC. CDC is a three-part measure. It includes an A1C test, a nephropathy screening, and a diabetic eye exam for patients with diabetes. There are some logistical challenges that prevent this measure from being completed via telehealth. We included it here because we want to recommend to continue staying engaged with diabetic patients via telehealth due to the risks of unmanaged diabetes. And then we recommend using these visits to either order or assess the timing of completing the test. We have several outpatient codes covered for telehealth that allow you to stay engaged with the population. And then I do want to call out that PHP recently added some eye exam codes to our telehealth policies, and these codes are not applicable to the diabetic eye exam because it requires view of the retina. And then even though we know that these services are not able to be completed via telehealth, we did call out some specific codes here that are explicitly excluded from telehealth just for clarity. So this measure is statins for patients with diabetes. It looks at members with diabetes who were dispensed or remained on at least one high-intensity or moderate intensity statins during the measurement year. So again, we recommend staying engaged with your diabetic population using a telehealth visit, and then leveraging this visit to discuss medication management or ordering medications if needed. And then if the member is not already using the mail order pharmacy, this visit would be a good opportunity to make the switch so that meds will be delivered to their door, and it will also save them the outing to the pharmacy. Are there any questions on these diabetes measures before we move on to the next section?
I do have a question. This is Jackie Thompson-Moore. Some of the other insurance companies have started doing the remote testing for patients for diabetes, for the A1Cs and the microalbumin. Is that something Providence is thinking of doing, or?
Hi, Jackie.
Like at-home testing?
Hi,
Yeah,
Sarah.
Hello. So we have historically avoided this the vendor solutions simply because we've
Correct.
often worked so closely with primary care and have really worked to support the primary care patient connection. We're hearing more and more from primary care that this is a unique year where the vendor solution with a home testing option could be valuable and welcomed. So we are internally exploring that as an option. We're talking with a vendor about that as a solution, and I'd say we're like midway through the exploration of really developing what that would look like and understanding
Okay.
cost and workflow. And again, it becomes complicated because the vendor solutions often bypass primary care, and we're committed to incorporating primary care. So our processes always seem to get more complicated when we do that. But I will tell you that's my long-winded answer because you know me and that's what I do. My short answer is that we hear that ask and we are exploring an option for that and hope to have some more information in the next couple of weeks.
Okay, sounds good. Because I know with some of the other vendors, what they're doing is the results actually go directly to the insurance company, and the insurance company actually forwards that information on to the primary care.
Yeah, yeah. We also
it's a critical high, and I guess then they're actually calling the offices to notify them
okay.
of the value.
Yeah, that's good to know. So we're exploring that and how to make sure results get back to the primary care in a timely manner. We're also exploring how to include primary care so that they know that they're participating in the ordering and know that the patient's getting that test. Because the kind of standard operating is that it doesn't route through the assigned or attributed primary care. They have different mechanisms for that. So I'm confident that there's a solution to that. It just means that the process takes a little bit longer to vet because it's not the standard operating procedures.
Thank you.
So you bet.
that was a great question. Thank you, Jackie. Any other questions? Okay, so we'll move on to the elderly population section. We have 3 measures here. We talk about osteoporosis management in women with a fracture, care for older adults, and statins in persons with ASCVD. So care for older adults has 4 components. This is the functional status assessment, medication review, pain assessment, and advanced care planning. This measure is for the DSNP population, which is Medicare, Medicaid, dual eligible patients. This is a especially important high-risk population to stay engaged with during this time. So we recommend using a telehealth visit to complete all 4 assessments. Knowing that there can be barriers or more limited computer or internet access, we do believe that this measure can be completed via phone only. So this is one where we have specifically called out ability to complete the measure via phone. We do recommend attempting to complete it via a 2-way video audio visit for reasons that Sarah recommended before, like limitations on risk coding for phone only visits. But if there is no other option, we do believe that all 4 assessments can be completed in an audio-only visit if there's no other option available to connect with this population. And we just recommend to really have complete documentation in the medical record in case we pull one of these visits for chart review to make sure that we can accurately complete the review for one of these visits. There are also several CPT Category 2 codes associated with these measures. So complete and accurate capture of these codes is key here for this measure as well. The next measure is osteoporosis management in women with a fracture. So this looks for either a bone mineral density test or initiation of osteoporosis drug treatment within 6 months post-fracture for women aged 67 to 85 years. Our recommended quality strategy here is to use a telehealth visit for fracture follow-up and to initiate osteoporosis drug treatment to prevent a subsequent fracture. Then we have the statins for patients with cardiovascular disease measure. So this looks at members with ASCVD who were dispensed or remained on at least one high-intensity or moderate-intensity statin medication during the measurement year. We recommend staying engaged with this population using a telehealth visit and then to leverage this visit to discuss medication management and order medications. And then again, if the member is not already using the mail order pharmacy, it would be a great opportunity to make the switch and transition to a 90-day supply. So are there any questions about this section? Hold on, I'm seeing a question come into the chat. So what are the COA CPT2 codes, or is there a full list? We can definitely connect with you after this meeting to give you the COA CPT Category 2 codes.
There is
Any
a list.
other questions?
We have a whole worksheet, Carolyn.
Okay, I'm going to hand it over to Sarah. She'll continue our measure review.
Thanks, Rebecca. So this next section covers, as you can see, depression and hypertension measures. So we've got AMM, antidepressant medication management, and CBP, controlling blood pressure. First, AMM, antidepressant medication management. This measure looks at patients with major depression who are treated with antidepressant medication. And this actually has 2 parts. So it's a numerator hit if the patient remains on their medication first for 12 weeks, is what we call the acute phase, and then for 6 months, which is what we refer to as the continuation phase. So we're looking at both acute and continuation medication management. So as Becca's been talking about, the medication measures really lend themselves well to telehealth. Again, those outpatient codes can be used to engage patients around their depression and medication management. So, we recommend using those telehealth touches to keep your patient engaged and supported and continuing to take those medications. On this measure specifically, we actually have some tips from Optum, our behavioral health partner, on behavioral health for primary care. So these first 2 bullet points really emphasize the diligence in determining who's appropriate for antidepressant medication. So recommending first considering a referral or a consult for talk therapy prior to medicating. And then the second bullet here, recommending use of standardized screening tools. So I think we're all familiar with the PHQ-9, but really using that as the tool for identifying appropriateness for medication. The second 2 bullet points talk more about patient education. So how long it may take for the medication to take full effect, any relevant side effects, the importance of adherence, value of psychotherapy, and recognition of mental health diagnoses as medical illness. So really using those to set the stage for adherence and success in their disease management. We do actually have a more robust tip sheet on behavioral health and primary care provided by Optum, so we can definitely share that as well. It's just, as you can see, we've already crammed a lot into this slide, so certainly couldn't fit anymore. Controlling blood pressure, probably one that you have all heard of and are very familiar with. This measure assesses patients with a diagnosis of hypertension and whether or not their blood pressure is under control. And HEDIS defines control as less than 140/90. So less than, not less than or equal to, but less than 140/90. So this measure presents difficulty in that there still isn't real acceptance from NCQA on the validity of home blood pressure monitoring. Currently, HEDIS criteria requires the information be directly downloaded from the patient's home monitoring device to the EMR, which, as you know even better than we do, is very rare that the device can communicate with any degree of ease with your EMR. We've consistently advocated, actually, in even pre-COVID years, for the inclusion of home monitoring and patient-reported value. You know, we've heard feedback from our providers, and also there's a large body of evidence supporting it and its clinical validity. So we recognize that home readings are valuable. We also know that they're accepted under CPC Plus measurement. So that creates a really difficult disconnect between the two programs, and we've emphasized that in our conversations with NCQA as well. So the good news is we're hearing more conversation from NCQA on this. It's another measure where we're hopeful for change and that these will start to be recognized, but we haven't received those confirmed updates. So as it stands today, we really recommend using those outpatient telehealth visits to engage patients, again, looking to medication management to maintain blood pressure levels, use 90-day supply if patients aren't already on it. We do think and hope that you already are using the home readings as part of your clinical assessment, even if they don't count in the HEDIS measurement. I think just be sure to note it as patient reported. When the patient does come back into the office at some point, which is the value that this measure currently is actually using, we hope that those telehealth engagements would help ensure blood pressure control, and then we'll, for the value that we are able to use. And then, of course, we'll definitely keep everyone updated as NCQA releases new information. As Becca mentioned, hopefully July 1st we'll have any relevant provisions on this measure, among others. Any questions on AMM or antidepressant medication management or controlling blood pressure? Transitions of care, we have really like one in a subset measure, TRC, transitions of care, and then medication reconciliation post-discharge, which is a component of transitions of care. So this measure is actually a 4-part measure that NCQA introduced not too long ago, just a couple of years ago. The measure requires notification of inpatient admission and discharge within 48 hours, so on the day of admission or the day of discharge or the day following it. Those are the first 2 components. And then the second 2 are the patient engagement and a medication reconciliation of both the discharge meds and the current meds within 30 days of discharge. So I have the second slide, as you saw, that focuses more on medication reconciliation. I think that's a measure we've been talking about for longer, and we may be a little bit more familiar with it. Transitions of care is the measure that NCQA is moving towards. They have intent to actually remove medication reconciliation since it's a component of this, and instead measure all 4 as an indicator of effective management of the patient's transition of care. So we're all going to become much more familiar with it very soon, I think. So I think the first 2 parts, that provider to provider communication, really shouldn't be impacted by the telehealth world. It's looking for timely notification when the patient gets admitted and then when they're discharged. So again, on the day of or the day following. The patient engagement component can be completed via telehealth. It's, again, those outpatient codes that you'd normally use, which, again, by our assessment are the overwhelming majority are covered. So really can transition those right into telehealth. The medication reconciliation can also be completed as part of that patient engagement. So you could do both of those at the same time, again, within that 30-day window. The transitional care management or TCM codes and those activities would also be relevant here. Again, the TCM codes actually require much more robust activities than what this specific measure is looking for. But if you're completing transitional care management activities and you're able to bill those codes, it would encompass the 2 patient engagement and medication reconciliation components of this measure. I won't go over this again, but I wanted to call it out because, again, it ties back to what Becca mentioned with the CPT Category 2 code. And so this is, again, looking for that medication reconciliation within 30 days of either a hospital or a SNF discharge. But the Category 2 code, so when we review chart documents for this measure as part of our HEDIS criteria, review process, there's really specific language that NCQA requires be used. You know, something like discharge medications were reconciled with current med list, or something like really clear and obvious that every T was crossed and I was dotted. The CPT Category 2 Code 1111F indicates that a medication reconciliation was completed and counts for this measure. So this is, back to what Becca was talking about with the importance of the Category 2 codes. If you're completing the service that fulfills the code, it allows for a clean administrative, or what we refer to as administrative, which means claims, capture of the information and takes away the guesswork of a chart review. We're also not sure what chart review is going to look like in a post-COVID or maybe still COVID, I hope not, but we don't really know, world. And so again, just emphasizing or reiterating Becca's point around those Category 2 and diagnosis codes, really just making for a clean capture of the information and again, and reporting of the quality performance. Transitions of care, MedRec questions or comments? All right, well, a couple of other measures that didn't fit as nicely into our strategic categories, but we thought still important to address. The first being rheumatoid arthritis management. So this measures patients with an RA diagnosis who are taking a DMARD. So again, falling under that medication management opportunity, really just recommend using those outpatient telehealth visits to engage patients with RA, ensure they're taking their meds, any barriers they're are able to address and help problem solve, and if appropriate, transitioning to that 90-day supply. Keeping them encouraging adherence with that, and also limiting trips to the pharmacy. The annual wellness visit, I will acknowledge at the outset, is not a HEDIS measure, but any of you who know me or who have talked to me have probably heard me talk about the annual wellness visit and what a fantastic tool it is, most specifically in the Medicare population in advancing clinical quality. So I'm plugging it in here anyway, but it is not a HEDIS measure. However, it's a really good tool for addressing a large majority of the HEDIS measures that we've just gone over. So I think everyone's familiar with the annual wellness visit being available to beneficiaries each calendar year, really to guide their preventive care decisions and to address their chronic care. As far as engaging patients virtually in an annual wellness visit, that initial AWV is going to be really difficult in that vision, hearing, and vitals are mandatory components of billing per Medicare. But the subsequent AWV, so the GO439, is ideal based on your clinical judgment. If this is a patient that you've seen and you have vitals within the last 12 months, then the virtual annual wellness visit becomes a really reasonable and valuable connection point. We do have a full guide available that we created in partnership with some of our PMG provider partners. So I won't go over this at the bottom, but if it's useful for you, we can certainly provide it, just helping outline some of the ways that that we'd recommend setting up these virtual visits. really completing the annual wellness visit in the normal manner, just without those physical exam components, and making sure that mini cog is still completed virtually. So our recommended quality strategy in that blue box there, where it's appropriate for the patient, considering those physical exam limitations, completing that via telehealth, and then just making sure that you are still setting a plan for obtaining the vitals or other services that would need to be done face-to-face, to make sure that that loop does
Sarah,
get closed when it's safe to do so.
Sarah, there's a question in the chat. Can HCCs be documented during a telehealth AWV visit and have them close those care gaps?
Yes. So a two-way audio video telehealth annual wellness visit is risk adjustable. So we would capture those HCCs and they would be part of the risk adjustment model. Yes. You bet. Thank you for asking. I'm trying not to talk about HCCs. It's a big part of my life too. So I appreciated the opportunity to put that plug in. Just another quick look at the really framework, the infrastructure that we categorized, I think, kind of based on your population and your area of either relevance or interest or appropriateness. We really wanted to set this up in a way that allowed for, okay, well, we really want to focus on our elderly population, or we have largely a pediatric population. So you can kind of hone in on specific areas or, of course, address all of them if so suited. Just brief summary of kind of what we've talked about today. We are putting in place payment policies to support telehealth. They actually just today were extended through the end of the year. So if you haven't been on ProvLink, you can go look at that. That was just published this afternoon. But we really want to support this work in the telehealth environment for you and for your patients. Our goal in this conversation today is to provide just education and information on how our payment policies are supported and aligned with HEDIS measurement. We would love to hear from you about additional quality activities that we didn't reference here, specifically ones that you feel could be delivered in a high value way via telehealth. I think that we're open at PHP to hearing how we may need to revisit our policies to make sure that we are supporting those activities. But then also as an advocacy opportunity back to NCQA, we take our advocacy role very seriously and definitely want to hear from you. Our providers have often informed some very good advocacy back to NCQA, so we really value that input as well. And finally, our guidance will continue to change as we gain new information, hopefully after July 1st when NCQA releases new information. But we're also, I think, awaiting CMS and any other regulators on, kind of just as the situation continues to evolve throughout the year. Okay. And with that, we have 7 minutes. I've included the 2 additional summits, so there'll be a replica of what you heard today on Monday and Wednesday of next week, and then another call out for the forum next Friday that I hope folks are able to attend so that we can have a really good learning session and kind of best practice sharing among peers for telehealth. So Janet, I see your question here around chronic care management. So I think let's you and I connect to answer questions about what we pay for, because I think that might be just outside of my realm of expertise. But let's chat, because I want to get you an answer. I just don't want it to be wrong. Any other questions or comments or anything that we can help with in this space? Rebecca and I are really teamed up between strategic accounts and quality to do everything we can to support primary care. We know that these are very hard and demanding times in so many ways. So just know that we are here and happy to help out and answer questions. Lisa, I see you indicating you also like to hear about the CCM, the chronic, whoa, my chat box. chronic care management codes. I just lost my chat box. Becca, can you see it? Thought there was one more.
Yes. Carolyn is asking how we will send out updates after July 1st.
I think
Will we be sending out the presentation from today? Okay. we'll take them one at a time.
yeah. So as far as communications after July 1st, I think, through GoToMeeting, we actually have a list of folks who attended today, so we can definitely send that out. I think that and the presentation will send out to everyone who attended. Absolutely. Does that cover them, Becca? I'm sorry, I don't know what happened to my.
Yeah, no, I think that is everything. And then there was also, earlier on, we discussed just more information on CPT Category 2 codes, so we can distribute that through this email list as well.
Perfect. Okay. Well, with 5 minutes remaining, we'll let everyone go. Thank you so much again for joining us today. Please do follow up with us if you have any questions, and hopefully we will host you next Friday for our forum. Thanks, everyone. Bye-bye.
Thank you.